Dr. Dileo, consultant oncologist at the sarcoma unit at University College Hospital. She's going to give a talk and reference some case studies, which hopefully will bring a bit of reality to everybody, and you'll be able to relate much easier to what she has to say. So I'll hand you over to Dr. Dileo.
Hello, can you hear me? Hi, good afternoon, everyone. So as Nick said, I am one of the medical oncologists at UCH, and in a team with other couple of my colleagues. Usually I'm somehow in charge of patients that have been diagnosed with GIST. A little bit of background for myself. I can see some familiar faces here, so I've trained in Italy and United States, and I've done a little bit more of focus on GIST since the very beginning of the Imatinib era. Let's say this. And the other thing that I want to say is that I've been asked to talk about somehow this treatment strategy, and with that, if possible, to show some of the cases. So I do apologize if someone in the audience kind of reconnect with the history of patients that are going to be shown in the next few minutes. I'm not going to talk for 1.5 hours, don't worry about that. Everybody is possibly familiar with what we do at it changes without even I have not done anything. Yeah, now I've just gone back. Okay, so we know about what happens in the early stage of localized disease, and the standard treatment remains the surgical approach. What we are here to discuss most likely is what happens when we are facing localized, advanced, or metastatic disease. So from history, we know that GIST are chemo and more or less resistant, although radiotherapy sometimes has been used for some specific issues. And the management has been somehow revolutionized by the advent of Imatinib at the beginning of the 2000s. What I'm going to try to do in this next minutes, try to talk about the 3 main scenarios. Patient have the first diagnosis and go on Imatinib, and patient who progress on Imatinib and go on to receive Sunitinib. And if they progress on Sunitinib, for what we have now, go on and receive Regorafenib, which are things that are being accepted and licensed, approved and licensed, both in Europe and United States, all over the world. The other possible scenarios that I might touch today is the use of the local treatment, when and if we do it, why we do it. And I'm talking about the radiofrequency ablation or the surgery, and if we do the surgeries because it's in presence of the focal progression or residual disease, and maybe talk about also the rare mutation and the expected response to treatment, as well as the neoadjuvant treatment, and maybe at the very end touch a little bit on the adjuvant treatment in terms of scenario of treatment algorithm. I'm not really sure whether or not someone of you has seen this, but it is possible. Again, I have not touched that. So this is the very first report on Imatinib, which was published at the end of the 2000, in the New England Journal of Medicine, and this is what was called patient 0, and you can see the pre and post PET scan of the patient that received Imatinib, and that was more or less few days after the very first treatment. On the top of the slides, you see the sort of correspondent area with the on the CT scan, which compared to the PET scan did show some response in terms of what we always expect to see when you are on treatment, like shrinkage or changes, but that came after many months compared to what we saw on a PET scan. So at that point, someone called Imatinib the magic bullet, and particularly that was because we came from a situation in which patient didn't even have a sort of therapeutic options, and going from being very sick to being in a very good performance status, which is the way one describes the fitness of the patient after a few weeks on the treatment. And so the targeted therapy, I'm not really sure what's happening with the computer, somehow made like a paradigm shift in the treatment of the disease, was a revolution, and it started a new era, and was obviously a long awaited breakthrough for patients with this diagnosis. So if we go back into what I've said before that I was going to talk about today, and we sort of for a moment put aside patients that have had surgery and are on follow-up after the surgery without the requirement of further treatment after the surgery apart from the follow-up, is the next step when patient present with a different situation. So what I briefly described here was, it is the history of a patient that was diagnosed not from us, elsewhere in May 2005, and he underwent a hemicolectomy and was kept on a sort of follow-up until the January 2015, when he presented again with a right abdominal pain, and then he went on to have all the staging investigations. And in March, the hospital where he was followed, they did a biopsy, and this was in keeping with GIST. And then when they retrieved the the very first diagnosis, they found out that was the same, exactly the same thing. At that point, at that point he was referred to us, and as you can see, and many of you are familiar, actually most likely everyone in this audience is familiar with that little phrase there, mutational analysis. We also asked to go deep in you're shaking your hand.
No. People saying the same thing.
Okay. So I thought that someone has been talking to you at the beginning of the day, but what that means is that when you have a diagnosis of GIST, is not only the diagnosis of GIST is important. Many things are important. Also, to go a little bit deeper in the biology and of the cell and understanding, thank you very much, understanding what has triggered the progression of the tumor and at what level. So there are areas in the responsible of the progression of the cancer that is the KIT gene that can be mutated. And at that point, mutational analysis means that you recognize where exactly they are mutated, and depending on the type of mutation, at this point, maybe not in 1998 or 2000, but certainly in 2016, we can say much more in terms of somehow, at least on paper, predict how someone is going to respond to a certain type of treatment. Does that make sense? So that is what we did. We asked also for the mutational analysis, and exon 11 was what this patient had in terms of the mutated gene. And also we now know that the exon 11 is one of the most common mutation and is actually on paper the most responsive somehow. But that doesn't mean that if you have another mutation, is not going to respond to other treatment. And I'm going to show something to give you examples. In this particular case was an exon 11. So the patient went on and commenced Imatinib at the very beginning at reduced dose to test the tolerability of the drug, considering that he is 82. So you have to consider also what is the toxicity and everything. But once we saw that he was tolerating the treatment, we increased the dose to the optimal level and went to 400 milligrams. So I'm going to show you, and again, I apologize if this can make someone upset, but this is the presentation, and these are the scans. This is April 2015, and this is July 2015. So what you are looking at, I don't know whether you, possibly many of you are familiar with this, but you are looking at the liver. This is the back, and this is the front, and then you can see that in April, this patient had quite a big lesion plus another lesion here. It was quite impressive, the beginning, and this is not the only. And then 3 months later, that big lesion went on, and what we see is here and possibly here. So this is another level of the same CT scan below the liver, and so you can see that in his abdomen there was quite a lot of extended disease, and again we can see a response to treatment quite impressive in 3 months. Also, the patient was very tired, extremely fatigued when he presented, and after a couple of weeks he was feeling much better. So clinically we knew that he was responding. This is another slide of the same CT scan, and you can see the difference in between the two before and after. And this is what happens somehow in terms of what we do when someone with a large extended disease comes to us. We ask for the staging process. We go through and ask also if we don't know already the mutational analysis, but then we start with the first line of treatment, which is Imatinib. And I think you are familiar with that. So what we do on disease progression, so we know that there is a percentage of patients that are either resistant to Imatinib, primary resistant to Imatinib, which means that somehow they don't tolerate the treatment to start with. And we also know from studies that there is a percentage of patients that develop progression on Imatinib. Whether or not this, most likely it would be because of the development of a secondary mutation which escape from the control somehow of the Imatinib itself. So the options are different, and the dose escalation of Imatinib is not necessarily something that we can do, and we have some information regarding the possibility of having benefit for some particular mutation, although in UK, we're not allowed to increase the dose to 800, but the reason why I put it there is because maybe you are on website, on internet, and you see around the world that someone says we have escalated to 800 milligrams of Imatinib. There are so far no real, there is nothing that is published that says that for sure there is an advantage of doing the 800, the higher dose, unless certain circumstances. So there are the medical treatments, surgery and RFA. RFA stands for radiofrequency ablation, and obviously the other things are the second line treatment with Sunitinib in the first instance. And so Sunitinib is a little bit different than Imatinib, meaning that it goes to as a broader spectrum of activity in terms of target, and is now approved in several other diseases, not only in GIST. Again, I give you this in an example with a PET scan. This is the baseline, and that is only after 7 days of Sunitinib. The arrows are pointed to normal physiological uptake of the contrast. So that was a very, very good response to treatment. And just this was an exon 9 in biology. So again, another case. So if we have a patient that has been on Imatinib before, and in this case was a patient, a 75-year-old male, diagnosed in 2004. He was deemed to be inoperable at the beginning, and he started Imatinib. So, and that is the time scale. So again, we did ask for the mutational analysis. and he was on Imatinib for quite a long period of time, which means that, as expected, he responded to treatment with Imatinib. Unfortunately, at a certain point, he progressed, and this was in December 2013. And at that point, he commenced Sunitinib. Now, I'm not sure, some of you are, are having treatment with Sunitinib, is going to be one of the question is the dose of Sunitinib, the recommended dose as a schedule, and sometimes you have patients that cannot tolerate that schedule. And for our point of view, this patient was on a reduced dose compared to the indicated dose, but on continuous dosing rather than with an interval, because the other the recommended the indicated doses is 50 milligrams, but with a break. So this is the patient scan, and that is the baseline when there was a progression to Imatinib. And so I can point for you the areas. This is one of the areas, and that is December, and this is July with a sort of reduction of the lesion. There is another area here further down. This one is a kidney cyst, so it's not related. There is no connection with the disease at all. This is the area that we are looking at, and this is what happens in July, a few months after, into the treatment. And here again, that's the area that we are looking at, and here is almost gone, is in between the bowels. So definitely smaller, and definitely this patient had a quite a good and prolonged response to Sunitinib. So that was the patient with the exon 11 mutation. If we go back a little bit, I've said before that there are suggestions that there is a difference in terms of how you respond to treatment or expected to respond to treatment on paper. And one of the things that we know is that patient with an exon 9 mutation first may be more sensitive to a higher dose of Imatinib, and it may be that as a better response to Sunitinib. Having said that, this patient was as a 54-year-old male diagnosed in 2012, and he responded for a little bit on Imatinib, and then but at that point we were allowed for only the exon 9 to increase the dose to 800, and he stayed on Imatinib for a little bit, and then in October 2013, unfortunately, progressed, and we started Sunitinib. I wanted to give you the feeling of the different response in the different mutation. Again, this is, I'm not really sure how to project because I can't really see it well, but this is October 2013, and that's 2 months later. There is involvement of what is called peritoneum, which in simple terms, it's this membrane that covers the bowel. And so there is disease, nodules around the peritoneum with a quite extensive disease on that area. And you can see that in this other CT scan, things are getting better. And this is another slide further down of the same CT scan with more area, more cystic area that is sometimes the change that you see when there is response to treatment. This is another one, and you can see the involvement of this area here that is also very solid, and here that less with a cystic component in this area here. Okay. So next step, again, if we follow what we said at the beginning, what happens when you have progression to Imatinib, and what happens when you have progression to Sunitinib. Thankfully, we do have now also, in the last couple of years now, the regorafenib is available, and this patient went through different line of treatment, and in 2016, in June 2016, has commenced regorafenib, and that was due to progression to Sunitinib. Again, I'm not sure this is relevant, is the molecule of regorafenib. So you can see here different areas that are involved, again, in between the bowels, and the same area with less involvement, still one nodule that is prominent, but the others are definitely responding to regorafenib, which is obviously very good. This is probably a little bit more intuitive here. There is this area that is the solid component, and it's shrinked quite nicely here. And the same here. More or less is further down. And this is what we, just to recap this, so far I've shown you that what we do. The other possible scenarios that we were talking about is when you have patients that are on Imatinib, for example, are responding well to Imatinib, and somehow at the CT scan you see what is called focal progression, and then you always ask yourself whether or not what to do, and whether or not you should change the treatment, or actually rather tailor the treatment around your patient, including using, for example, the local treatment. So I'm going to show you this one. This is a patient that had a focal progression to Imatinib. A 65-year-old male diagnosed in January 2014, so 12 years ago, and has gone through different treatment, not only, however, Imatinib in terms, not systemic treatment, because the Imatinib is the backbone of this treatment. But then the patient also had some of the liver lesions that were or resected because they were progressing on the background of stable disease or responding disease, or ablated with radiofrequency ablation. I'm going to show you the last one, which is the July 2010, which was, it is 6 years ago, when he presented, and again, he's still on Imatinib, with a single site of recurrence in the liver, which was ablated with radiofrequency ablation. And this is the scan. So you can see here the lesion. So you probably can see from there that there is a sort of more central part of this lesion that is a little bit more white, gray, and then blackish around. That area is the solid component, and the cystic component all around. So this was ablated. So they went in with a needle and they did the ablation. And this is in November 2010, so a few months later. You can see that it's a little bit smaller with no solid component in between, within the lesion, which means that there has been a response to the radiofrequency ablation. And this is the same patient with a CT scan from December to 2015. In the same area, we cannot see anything. And June 2016, it remains somehow free of visible disease, which means that the patient has been allowed to continue his Imatinib for all this time and have only the very focal progression taken care of with something different, which was or the surgery or the radiofrequency ablation. So when it's possible, you always think about those procedures as well. There is also something that one can call, I'm sorry, it's still doing very strange things, what is called, personalized surgery in advanced disease. And why you do that? You do that when you can resect what is called minimal residual disease. Let's say that the patient responds very well and you have just a focus of the lesion, or you have the primary in the stomach that you have to take care of, and that is something that maybe you want to do that. And also the same thing for the focal progression. There are several reports more than studies. I'm not really sure what's happening. So sorry, but it's doing it without me.
One of the buttons is a bit.
Yeah.
Could you explain
Yeah.
focal?
Focal. So it means that you have, let's say that you have a patient with multiple liver disease.
Yeah.
And you do a scan and the patient is on Imatinib or whatever it is, but let's take Imatinib. Every single lesion but one or two are stable or responding, and those two are progressing. So it's a sort of discordant response.
Yeah.
So somehow you understand that the patient is still benefiting from Imatinib, but there are some clonal some cell that have escaped that. So that's the focal or the clonal progression. And that's the reason why you say, I don't want to maybe discard the treatment with Imatinib all at once, and I want to understand whether I can do something specifically for those one or two lesions. And that's the radiofrequency ablation comes on, or if you can do the surgery, depending on the situation. That's not necessarily something that you do all the time, and I'm not encouraging to do this all the time, but it's very specific when you have only one single lesion or one other lesion that is amenable for that procedure. Does that answer your question? No problem. I'm going to try to go back to... Okay, so there are, as I said, there are few reports regarding the surgery of the residual lesion, but there has been, there was an attempt to do a study, but it was not feasible in between the centers. It was really difficult to get patient on and on board, both in the two sides of the ocean, not only in Europe but also in the United States. So the only thing that we have regarding the surgery of the residual disease are only sort of case report so far. One of the other things that I mentioned in my initial slides is talking about other possible scenarios. So you see that there, Imatinib in wild type. What does that mean? Before you ask me about the mutational analysis. So if you go into the slides and you ask your pathologist to go into and look at the biology and look at whether or not there is a mutated gene, then they will screen everything and tell you whether or not you see something. And if there is no mutation for KIT, for the PDGFR alpha, and then lately BRAF, or whether or not you have SDHB expression. We're not going to go into those details, don't worry. Then very broadly, patients are called, they have this definition of wild type. It might not be the right, and you're looking at me like, I know what you're talking about. But let's call it wild type right now. And in this particular cases, and one of the things that we always said is that we don't know if patients that are not KIT mutated, or they have not a very particular a mutation in another area, are going to respond to Imatinib. So what I'm saying here is that not necessarily that's true all the time, and that's the reason why, despite what we say, what we know, the very first attempt is anyway Imatinib, because you don't know whether or not you're going to get any response. In this particular case, we had something that I'm showing there is the primary lesion and the lesion in some lesion in the liver. And after few months, there was a very good response, which somehow someone can say, oh, it's unexpected. And yes, it was unexpected, but thankfully things weren't on well.
Was that in the UK?
Yes, it was. So this is another area which a very good response as well. And this is exactly, so that particular patient, a certain point, had a scan that says there is a progression on Imatinib. What should we do? And again, we said, okay, we'll go on and try Sunitinib. Again, with that particular background, on paper, you don't know whether or not you're going to have any response to treatment, but thankfully that happened. So this is the area, and you almost can see it here. It's very small, it's here. And the same here. There is a very good response here and there. And that was just to say that sometimes, even with the rare mutation, we just need to try and go with what we have and understand whether this is going to take us with something. The same with regorafenib. And by the way, with regorafenib it's a little bit different because on paper we knew already that there was something different from the study. So this patient is again a patient with a genotype that is negative for KIT, for PDGFR alpha, BRAF, and with a loss of SDHB expression. So he went on to have Imatinib and Sunitinib, and he stayed on Imatinib and Sunitinib, and this is the difference. You can see that the timing is short in between Imatinib progression to Sunitinib and also Sunitinib to regorafenib, which is completely different from the patient that I've showed you before, even if they have more or less the same genotyping. But this is a response to regorafenib. It's a very nice response to regorafenib. Here, the liver lesions with a very solid component of the lesion. And here, although you can still see the same, more or less the same, they are more necrotic and less solid inside, which is a sign of response to treatment. Same here, the same thing that we can see here, this side and this side. And here is a little bit more intuitive. This area here is a little bit smaller with a more necrotic, a more cystic component within the lesion. I promise we are almost done. We also talk about at the very beginning of whether or not there are other ways to go. So obviously we have a patient that can have a very simple, straightforward pathway. A patient that comes to you, they go to the surgeon and have a small lesion in the stomach that can be resected with a sleeve gastrectomy, and that's okay, because that is the standard. However, we are considering the use of the neoadjuvant Imatinib. And when do you do that? You do that in specific presentation. For example, when you have an extended lesion, a large lesion in the stomach, which will require a total gastrectomy, and unless you know for sure that because of the site of origin of whether or not it's in the lesser curve or the great curve of the stomach, that is a technical issue. But if the surgeon says, with a smaller lesion, I can have a less invasive surgery, then you always consider whether or not doing the neoadjuvant treatment. The other area is when you have a presentation in this esophagus, and which is very kind of rare, and in the rectal area. In this particular case, this 50-year-old male presented quite recently with 10 centimeter rectal mass, and morphologically was a GIST. We asked for the mutational analysis, was an exon 11, which, by the way, is quite frequently in that area. And he commenced Imatinib in mid-July. I'm going to show you two imaging and point out where the lesion is. So this is the area, this is the rectum, and this is the disease in July. This is September. So it's quite remarkable, considering that obviously the surgery in that area can be extremely complex and might mean a big operation with a stoma and things like that. So that means that maybe, and obviously he needs to see the surgeon, maybe things can be different. So that's the same area, but this is a different projection. Here you see the lesion, and you can see here that is extremely small. The comparison is remarkable. So I'm going to talk very briefly and actually maybe show you all only 1 or 2 slides. It's jumping. Anyway, fine. So you know, you might have heard about the possibility of doing adjuvant treatment, and the adjuvant treatment means that a patient has had surgery, doesn't have any spread anywhere, but when the pathologists look under the microscope, identify some risk category. The risk category are given by the dimension, the site, and the size of the lesion itself, which very briefly define a low risk, intermediate risk, and high risk. And on the basis of, right now, at least 3 adjuvant studies, we know that for high-risk patients with a certain mutation, the adjuvant treatment, which means after the surgery, it may be beneficial. And that's more or less what we do. We review the patient after the surgery. We ask all the questions, including the mutational analysis. And we have patients, we know that we suggest or recommend, and ultimately it's the patient that will say whether or not we'll go through, but we recommend treatment after surgery on the basis of those risk category and whether or not there is a certain mutation. And I think that's all for me. I don't think we need to look at these slides. I hope I have covered everything in terms of treatment strategy and example. I'm happy to answer other questions if you have one. I'm not sure I will.
Thank you very much for that. In fact, the last description that you had of adjuvant treatment is exactly what I went through. I don't know if anybody else in the room. So I had a tumour removed. It was looked at and it was resected completely. In fact, they thought it was 3 centimetres in diameter, and they said they would do keyhole surgery to get it out. My wife came with me to the hospital, and I expected to be back with her sort of 3 hours after I went down. 11 hours later, I was still in surgery because they found out it was actually 8 centimetres in diameter, which isn't massive in GIST terms, but it was where the esophagus meets the stomach. So it was difficult to get out. So I looked like somebody sort of stabbed me 5 times and then ripped at the middle of my stomach in order to get this GIST out. It's all repaired now, and I look, well, I won't explain how I look, but when they tested it, it had a mitotic count, and the slide that you weren't able to show, it kept skipping.
Yeah, it was skipping. I don't know why.
Yeah, it was showing mitotic count, and
I'll try to.
If we can get it back.
I thought that was nice to show, but I don't know why it's skipping it.
There you
Okay,
go.
this one. So this is one of the first. It's the Mark-Metinen classification in 2006, and he is the one responsible for giving us GIST to be because he's one of the pathologists that was collaborating with Dr. Lasota, and they looked at the slides. I'm sorry, Nick, if I interrupt you for a second. And they looked at the slides and they said, okay, this is definitely not a leiomyosarcoma. There must be something different. So they went down into the cell and they identified what is called Cahal cell, the cell of Cahal, which is the pathologist that first described it, and is essentially that cell is the responsible, the pacemaker of what is contracting the esophagus, the gastric wall and everything. So that is the responsible. So, and they definitely said, this is a different sarcoma. And up until then, everyone was calling GIST in a different way. They were calling leiomyosarcoma, they were calling plexofibroma, schwannoma of the gut, whatever. And after that, they did that. They changed the name, and then a few years later, they were able to do a classification. This is not the only one, but this is the simplest that I could find to show you.
So on the left-hand side there, you've got greater than 5 out of 50 high-powered fields, which basically they take your tumour, they cut it up and put it into a grid, and then they count the number of multiplications of it.
It looks almost. It seems really strange to say that in 2016 they have to count the mitotic, the how many times a cell multiply itself, but it's what they do. They put it under the microscope and they measure like a sort of square centimeter or square, and they have said less of more than 5 per 50 high power field. That is a measure that the pathology used. And so if they count that in that little square they have 2 centimeters, they multiply for the power field and they come up with a number. So for example, you have a lesion that is more than 5 centimeters, but less than 10 centimeters, as in the gastric area, and then you go here. If it's less than 5 mitotic count, obviously it depends on where they say, because the same thing, but if it's the mitotic count is higher, then becomes high, the same diameter, the same size. So it depends on how many times the cell multiply themselves, and that is very important. And you find yourself in what is called risk category, and that's the reason why. And we also have this kind of separated the area, if it's the stomach, if it's the jejunal, the duodenum or the rectum, depending on geographically where it is.
So mine was good because it was a gastric gist. It was in the stomach. I say good. I'm using that term loosely. So it was a gastric gist, which is okay. It was 7 centimeters, so it was less than 10, greater than 5, but less than 10, which isn't quite so good. But at least it wasn't larger than 10. But they only counted 25 HPFs, and mine was 32. So they double that to get out of 50, which is 64. Now you can see that above 5 is medium, and I think above 10 is high. So 63 is really high. So therefore they said to me, yours is in a high risk category, so we're going to put you on adjuvant Imatinib. So I was on Imatinib for 3.5 years. Now, I don't...
By high risk, they mean high risk of returning?
Yeah, high risk of it coming back. It's multiplying quickly, so the chance of it coming back is pretty high. But what we don't know, because it was completely removed, is whether or not the Imatinib actually did anything for me. So I spent 3.5 years on Imatinib, not feeling great for that period of time, not knowing whether it was doing any good. But there is evidence through all these trials and tests that suggest that it does help from it coming back. And I've now been off it just over 2 years now with no recurrence. But as you guys will probably find, the most nervous time is that week up until your CT scan, where you're thinking, oh, I can feel something, there's definitely something going on in there. You go and have a CT scan and touch wood, it's all clear at the moment. You haven't had any signs of the disease coming back. But, it begs the question, what if I didn't go on the Imatinib for the 3.5 years? Would I still be in the same situation now, but without feeling ill for 3.5 years? Or may it have come back earlier? So we have to go with the experts on what they say and follow the advice and go on the Imatinib. So that's where I am and where I was, and I'm sure that there are people in this room that have similar and much wider ranging stories. But does anybody have any questions for Dr. Dileo?
Thank you. A couple of questions.
Sure.
Can you remind me, can you have multiple mutations simultaneously?
That's a good question. So it's difficult to, obviously, on the basis of the biopsy, especially if you do it on a biopsy, it's going to be difficult to answer that question, meaning that you biopsy one side and you don't biopsy the entire specimen. So it's not been proved that you can have a different mutation in the same tumor, but it is possible. What is being proved, however, is that when you have a progression and there is a possibility, especially if you are able to analyze what is the area that is progressing, that it could be because of a secondary mutation that has developed, and that is the reason why you somehow escaped the treatment. So there is right now is an old study, but it was done just around the timing of before Sunitinib was approved, and that was the time in which we saw that there were patients with different mutation in the same tumor. But in the very first time, at the very first moment of it is not proved that you can have a different mutation in the same, and so at the very first diagnosis.
And secondly, regarding diagnosis, could you just remind me the merits of CT scans versus MRI? Just to personalize this, I'm high risk. After 3 years of CT scans, I decided I didn't want any more radiation, having 2 CT scans a year, and I've gone over to MRI. But I can't remember, whether, for example, you get significant radiation twice a year, or whether there's any proper disadvantage of the MRIs.
No, okay. So obviously, if you have a CT scan, there is a possibility, there is an increased exposure to radiation, and it's always thinking about balance and why you're doing that and everything. So in the past, has been used also the MRI, and for example, for the small bowel cyst, we use the MRI as well. For the rectal cyst, we use the MRI, especially when we are looking at the anatomical definition, because with the CT scan, it's not going to be possible to have the same level of specificity, let's put it more than sensibility. So there are some particular area or anatomical area in which the MRI is easier to, is better to do. But we still do the CT scan because, and it's whether or not you complete the CT scan with the thorax, with the chest, considering that it's less common to have lesion in the chest. So we are trying to sort of say in terms of follow-up, the guidelines for the follow-up, but it is true that everywhere, almost everywhere in the world, the majority are using the CT scan because it's also easier sometimes to look at area of your abdomen that have gone through surgery with the CT scan rather than the MRI. But if you are in a center that has an expert radiologist that is kind of used to look at the scan of GIST patient, MRI can be used. You have to consider that it depends on how many times a year you do the CT scan as well. It's not a big exposure to radiation, and again, the balance.
So some advice that I would certainly give to everybody, and that we've learned really from both Professor Judson and Dr. Dileo's speeches, are people are asking, what is mutation analysis? That's one thing that every GIST patient, I believe, ought to know, because that would make a lot more sense as what's being said here. You'll understand more when they're talking about exon 11, exon 9, etc., etc. So it'll help you understand what type of GIST you've got, and you can relate that to risk category as well. So the second one is size, the size of your GIST, which most people know anyway. And the third one, and it seems to be the one that most people don't know, is the mitotic count, because that is also important, and it's the three elements that make up this risk analysis, or this risk assessment of risk of your GIST coming back, and whether it's high or low. So those three things are the three things that I would advise. And another one is, and you just touched on it then, which is get an expert in looking at radiology for GISTs. If you can do that, make sure that every CT scan that you have is looked at by the same radiologist if you can, because they will pick up any changes. They're likely to pick up any changes maybe a little bit better than different ones looking at it every time. I was advised that by my oncologist, actually, and he now makes sure that the same radiologist looks at my CT scan every time that I go. So
that might not be possible in big hospitals. I just wanted to let you know that it's a different time now that it was at the very beginning, when what is called response assessment was very kind of complicated, and people were not used to look at those kind of changes, meaning that maybe the lesion in the liver seemed even bigger than it was to start with, but the problem was that inside, as I showed you in some of the picture, instead of being very solid, it was very cystic, and that was the reason why they mistakenly were labeling a patient as a progressive on progression, and now is a different time. Is easier, and you most likely go in either a big center or a small center. But even if you are in a small center, most likely you will have the same radiologist or the same team of radiologists looking after that. In a bigger center, you might not have the same radiologist looking at every single scan, but that team of radiologists is now very used to it. And if there is a doubt, your oncologist, to start with, will question that report. Rather, so that is the thing that one needs to consider.
One of the questions was, I think for most people in the room, new or old gisters, is where the heck has the thing come from? There's various sizes. Just a point of interest on scans. I'm up on my first 6-month scan next week, and the oncologist said, look, if you're not happy, you can have them every 3 months. Well, I'm going to go back to 3 months. I'll take the risk where the radiation's concerned, because I'd rather know what's happening. But one of the common denominators is to go back to our friend Senor Cajal, or Cajal, was he Spanish? Cajal, or you speak Spanish? In 1934, he discovered the point about what they call it, peristaltic action.
That's correct.
Where your muscles start to.
Yeah.
Now, what if we mention him and he comes into the equation? How do we connect that with the GIST? And what's the, what really, I mean, we mentioned him. What's the benefit of knowing about the peristaltic action?
He described that lesion, that cell, which is the cell that usually makes the contraction,
Yes.
so the peristaltic action. It's not that there is necessarily a relationship between the peristalsis and the gist itself. It's just that in that cell you can see the mutation that triggered the cancer itself.
Right.
So and is whether or not that cell can be mutated as the gene that is then mutated and then trigger the progression and trigger the cancer itself. So I don't think that the peristalsis is responsible to the cancer, if you are implying that.
No. I'm looking for a common denominator. I mean, is it the fact that we all drink wine, or maybe everybody smokes in here? I don't know. Is there something there?
At the moment.
I mean, when we first came out with, Glyvec was on the front of Time magazine, wasn't it? The
Sure.
wonder drug,
Yes,
the silver bullet,
it
or
was.
whatever they called it. And you could almost say by accident, because it's primarily for people with chronic myeloid leukemia. So
It was
it
by
might
accident.
sound a silly question, but is there something as simple as that?
No,
that could help
it's
with
not a
gisters?
silly question. If you are looking for like a cause effect, you have something, and then that's something necessary, like smoking can trigger some lung cancer, or some lifestyle can have a link with the colon cancer, for example. Right now, we don't have any direct link between.
Right.
We just know that is the primer. Most likely, that cell is the responsible of the cancer is inside, because there is a gene that is mutated inside that.
Right.
But that there isn't. I'm not going to tell you that if you drink, 10 cup of tea, then you will have necessarily the gist afterwards. We don't have that link, that connect.
Could it be being married for 50 years, the stress of that? Could that be a factor, you think?
Are you sure that you want to say that?
No, because I've only been married for 20. You talking about Chip? Anyway, any other questions? Yes.
Thank you. As a discharged after 10 years of CT scans, surgery but no treatment. I'm about to have a CT scan tomorrow because of what's thought to be a surgical hernia. On the general correspondence that progressed, that spreads between us, there have been apparently recurrences of GIST which look extremely like a hernia.
Mm-hmm.
Can I ask my local hospital, because I'm no longer involved with the GIST hospital, can I ask my local hospital to have my CT scan sent to a centre where there is a GIST radiologist?
If you are questioning whether or not there is a recurrence because you want a second opinion regarding whether or not that is a recurrence, so I think that at this point is going to be, I'm not saying easy, but unless it's really controversial, the radiologist will, who most likely has some sort of history and why you having the CT scan, it might be able to do the connection and to make the connection and see whether or not there is any doubt in terms of, and the other thing is, if there is any doubt, they might ask for a biopsy again to find out whether or not there is something. I was not suggesting necessarily that you have to send every time your CT scan elsewhere. I'm saying that your oncologist, and I'm pretty sure that you are in very good hands, or surgeon.
No oncology treatment, no oncology link.
Okay. but you're gonna be referred to someone at a certain point, and most likely you're gonna be back to your oncologist, the oncologist that was following you before the discharge. And obviously we kind of, let's put it in this way. Let's hope that is nothing, but if it was something, then your oncologist will guide you in what to do and whether or not there is any further imaging requested, biopsy requested, what. They always go through, we always tend to discuss this in what is called MDT, which is the multidisciplinary team meeting. So I think that there's going to be more than one person looking after your scan at that point. So I don't think that unless there is a doubt, there is necessarily the need to send the scan elsewhere.
I think for your own peace of mind, if I were you, I would, when you go for your scan, just say, I've had GIST before, can you make sure that whoever looks at it looks to see whether or not there's any chance it could be a GIST, and if they're unsure, can they send it on to somebody else who could be sure about it, just to be sure.